Hi, everybody. We are going to go over now some parts of the genitourinary tract that are associated with infections. So we're going to start out. I'm just playing around with my little thing here, and it's seeming to work just fine. Okay, so we're going to start out with just the different parts of the genitourinary tract that can become infected. This is hard to tell what it is, but this is a bisected kidney. So we'll talk about how infections can reach the kidneys. So these can be hematogenous, meaning they travel through the bloodstream, and those are really dangerous infections. But if you notice this outermost cortical layer of the kidneys, that's indicative of these recurrent bouts of what we call pyelonephritis. So that's the upper genitourinary tract, would be a kidney infection. Below that, we have the bladder, obviously. And when the bladder is infected, we call that cystitis. One thing I want to point out is that there is different anatomy in males and females. So males have a prostate and females do not. So you will see that in these different disorders, prostate enlargement, which is associated with just aging in general, is something that is going to affect males. When the prostate does get larger, you will see urine start to stagnate there in the bladder. And so remember that the rule here in the kidneys and all parts of the genitourinary tract is that urine is sterile as long as it is moving. So anything that is going to stagnate urine production can lead to possible infections. So we'll start out at the bottom with what we call a UTI, or a urinary infection, urinary tract infection. So when we talk about that, that's urethritis, so inflammation of the urethra. And I want you to notice that this is not a normally colored urine. It is cloudy. It is a dark color. It looks a little bit frothy. And that's indicative of something abnormal going on. A urinary tract infection is a relatively common infection, and it is most commonly caused by ascending bacteria, which really just means bacteria that moves up into the urethra from generally the external environment. The best way to ensure that we're not going to see these UTIs in individuals is to make sure there's a free flow of urine. Well, that just cross that out. Let's do this instead. A free flow of urine, because urine is sterile as long as it is moving. Also, having an acidic urine is something that is going to kill, hopefully, the bacteria as it travels through it. Travels through the urethra. And not only having this nice stable pH of the urine, but ensuring that there's a large volume of urine. And when you have a large volume of urine, that ensures that the bladder can empty completely. When there are attempts to empty the bladder where there is a smaller volume of urine, the detrusor muscle has a really difficult time fully emptying that. So that can leave a small amount of urine behind to stagnate. Predisposing factors are primarily going to be impaired drainage, so something preventing the free flow of urine, because, again, anything that stagnates it, like a kidney stone, for example, can cause this. Or this can also be introduced in an ascending way with the use of something like a Foley catheter. Staph bacteria is everywhere, on hands, in hospitals, and even the most germ-free of locations. We can still find bacteria. So this can be introduced in a variety of ways. So the best way to prevent a urinary tract infection after catheterization, after intercourse, after anything, is just to empty the bladder. So urinating, but also drinking a lot throughout the day so that it is a large volume of urine. If by chance a urinary tract infection is not cleared, and obviously this is bacteria, so that means antibiotics are something that do treat it really easily. It can then flow up then to the bladder, which we refer to as cystitis, inflammation of the bladder. And so what you're looking at here, these are some cross sections of bladders in various states of infection. So we can actually see some granulomas in this picture. We can see some purulent exudate. So that's the pus indicative of an infection. And what I also want you to notice is this detrusor muscle, and you can see a better view of it down here. This inner muscular layer of the bladder is called the detrusor muscle, and the detrusor muscle's job is to contract when it senses that the contents of the bladder are full. So if this was filled with urine, the detrusor muscle would contract. That sends a message up to the spinal cord to close these sphincters down at the bottom. And it also sends a message up to the brain that says, let's urinate when it is convenient. When there is bacteria that is convalescing essentially in the bladder, remember, bacteria, they engage in fermentation processes. They make things bubbly. That's why things like beer are bubbly, because of bacteria engaging in fermentation. What that means for humans is if we have bacteria in places like the bladder, and my dog was probably going to bark, please be aware that I'm trying to stop her. She's also 10 pounds, so she's not big, so stop it. Okay. Okay. So when bacteria are in there, they're going to be making gases, and instead of having urine that is filling up the bladder, you're going to have bubbles of gas. So there will be the sensation that the bladder is full, although it's not full with urine, it's full with gas. That means that the detrusor muscle is going to keep contracting, keep sending a message up to the brain that it's time to urinate. So there will be this increased urge associated with bacteria there because the bladder is getting the message that it's full. Bladder infections are way more common in women because they have a much shorter urethra than men do. When men have ascending bacteria enter the urethra, just because of the length of the urethra, you usually see that even just a night isn't enough time for the bacteria to migrate up to the bladder before there's urination in the morning. So women are way more likely to have UTIs in general and bladder infections. However, you will see bladder infections in males, especially recurrent bladder infections when the prostate starts to enlarge, which is common around the age of 45. It just starts to grow and it never stops growing. So that will determine how much urine stagnation there is. And when somebody has a bladder infection, it hurts very badly. So there'll be a burning pain with urination. Because remember, urine is acidic. So if there is damaged tissue, acidic substances touching it is going to hurt. When you do a test of the urine, you'll see bacteria and leukocytes, so specialized white blood cells, are prevalent in the urine. That tells you that those white blood cells, like we can see these little areas of infection up here, that they're present in the bladder to fight that ongoing infection. And because it's bacteria, that means it responds to antibiotics, but if it's not treated with antibiotics, it may spread upwards. So just to keep that in mind, we have a little picture up here. This is Azo. This is a medication that's sold over the counter for things like urinary tract infections and bladder infections. But the main ingredient of it is called benzocaine. It ends in a cane, like cocaine. That means it's based off of the structure of cocaine. And it also means that it's an anesthetic agent. So these things work really well to get rid of pain. See how it says urinary pain relief on here. They do not remove the infection. They're not going to encourage the bacteria to die. All that it does is build up in the bladder. So now this is azo in here in my drawing, and it's filled with this numbing agent. It will numb the bladder walls so that the detrusor muscle is not going to contract so often. And then when the urine flows down the urethra, it is going to relieve that pain as well. The problem with using this is it can make somebody forget that they have so much pain associated with the urinary tract infection or a bladder infection. So it's very important that they go on antibiotics in addition to this over-the-counter anti-pain numbing medication. If not, it can spread upwards to the kidneys, which we refer to as pyelonephritis. All right, nephritis, inflammation of the kidneys. This is the most common renal disease that people present with in clinical cases. And it's really an inflammation of the renal interstitium, which, as we saw, is just the connective tissue. So down here we have the medullary region inside of the C, and out here we have the cortex. So essentially you're seeing just all purulent exudate there. So down here we've got some clear serous exudate, and up here it's a little bit more purulent. You see this also in the cross section of the kidney where we have the aggregation of this purulent exudate. The glomeruli are not affected because, remember, most of the functional units of the kidneys are over here in the medulla. So that means that we're not going to have any damage to filtration, because that's the glomerulus's job, to filter things. When there's a bladder infection and it's propagated by this incomplete bladder emptying, the bacteria proliferate, they spread, they repopulate, and then they spread upwards to the kidneys. When individuals have chronic cases of this, like we saw in this first slide, this leads to a state of renal failure that we then have to deal with on a more clinical level. So taking into account the different ways that this can be spread. So as I mentioned, it can be hematogenous in nature, meaning that it comes from the blood, a blood-borne type of infection. That's really dangerous. You do see these with resistant or antibiotic resistant strains of E. coli, which are just traveling through the bloodstream, and all the blood eventually is going to get to the kidneys. So those will eventually travel there. That's very, very difficult to treat. Those individuals are hospitalized. They definitely have to be hospitalized. It's a very serious infection, especially if there's resistant species of bacteria. The main cause that I mentioned before is going to be these ascending types of bacteria. So this can be from microorganisms in the vaginal tract that are right next to the urethral opening in females. So if those migrate there, they can spread up to the urethra. Just general exogenous microorganisms. So those can be really any type of bacteria or in some cases like a fungal type of infection that makes its way to the urethra, and then intestinal microorganisms. So those would come to the urethra in a couple of ways. One would be anal intercourse. It's important that patients know that there shouldn't be a switching between vaginal or anal intercourse without changing a condom or washing in between, because introducing E. coli, which we know is in the GI tract, to the vaginal tract, which is right next to the urethra, would be a way to introduce that type of bacteria that way. You also see that just wiping back to front instead of front to back in females would be carrying intestinal bacteria to the vaginal and urethral openings. So that's really important not to wipe in the incorrect direction, because you'll have this bacteria. Again, it'll first go to the urethra. You get inflammation, infection, pain there, then the ureter and bladder, infection, pain there, and then finally the kidneys. And if this happens chronically, that does cause some chronic damage leading to possible renal failure. Other things that just cause general stagnation, we'll talk about kidney stones in just a second. Prostate enlargement in males, as we mentioned, after the age of 45, it just goes off and starts growing. Pregnancy, the uterus sits right on top of the bladder. So when there is a fetus growing, the larger the fetus is, the more likely it's going to change the ease of bladder emptying. Pelvic inflammatory disorders, which can be trafficked through sexually transmitted infections or through just surgical interventions in the pelvic area. Tumors that can secrete abnormal substances or stagnate flow if it's a bladder tumor. And then that congenital malformation we've talked about, where there's that Y-shaped ureter and you get backflow of filtrate up into the kidneys. So again, just to tie this up, pyelonephritis, the most common type of kidney infection that is reported in clinical settings. So it can either be acute, so this would be an ascending nature.
It's common and mild. It's from this ascending bacteria. You can see this suppuration, which means, that the pussiness of the tissues. You'll see people are really sick. It hurts really bad. They have chills. They have a fever. There's actual pus in the urine. So that's a really important clinical finding. And then there's also possible bacteria in the urine. So this one is the more common, just an acute kidney infection, where a chronic infection is caused by long-term stagnation and recurrent acute infections. And when these are chronic and they're constantly occurring, there's a slow degeneration of the kidney function. The parenchyma, which is the functional tissue of the kidneys, is replaced by scar tissue. And as you know, scar tissue does not have physiologic functionality in the body. So that is going to limit the ability of the kidneys to filter products and help make a concentrated urine. You will see, again, pain, fever, hypertension because of electrolyte and fluid imbalances, and potassium retention because of secretion that should be happening at the end of trafficking through the nephron. This leads to the gross, and gross means just by looking at it, you can see that the kidneys are scarred in nature. So it leads to gross scarring of the kidney, and most importantly, scar tissue has no function. So this can progress to full-on renal failure. Some other things, the final one that can lead to full-on renal failure is interstitial. So that means the interstitial tissue, the inside, like right here, interstitial tissue nephritis, inflammation of the kidneys, the interstitial tissue. This is caused by something other than an infection. So pyelonephritis was having to do with bacteria propagation. Here, this is something else. So you can see this after radiation. If the kidneys are in the field of radiation, it is possible that their interstitial tissue can become scarred. This leads to tubular injury through ischemia, and the renal tubules are responsible for ultrafiltration, and also fibrosis or scarring of the interstitium. Again, we'll see that interstitial fibrosis, scar tissue has no function. The other common way to get this, there's only two ways to see this besides, bacteria. That's why this has a specific separate justification for it, is analgesic, an analgesic nephropathy. So literally that means like apathy is disease, nephro is nephron or kidney, and analgesics are pain relieving drugs. When people mix NSAIDs, so that would be your ibuprofen, your aspirin, plus acetaminophen, which is Tylenol. When that is done for a long-term basis, that causes specific changes to the functionality of the kidneys. The kidneys are overtaxed with excreting both of those substances, and in some cases doing some biotransformation things within the tubule. So this will progress to failure of the renal tubule and excessive urination. The primary state you see with this is metabolic acidosis. Remember, metabolic before acidosis means that it's caused by something else besides an altered respiratory rate. And once you see that phase occur, that can progress again to renal failure. So we want to make sure that urine is not stagnating. People take good protections against bacteria building up by urinating often, urinating a lot by drinking a lot of fluids throughout the day, and avoiding things like mixing aspirin and Tylenol on a regular basis to prevent all of these things that can damage the interstitium of the kidneys and then lead to renal failure. So one thing we keep mentioning in all of these slides is the possibility of a kidney stone causing urine stagnation. So these are called renal calculi or urinary calculi. They're called urinary in some cases because they can form anywhere in the urinary tract. So when people call them kidney stones, it's a little bit misleading because they can form anywhere. This one, almost looks like an ostrich egg. It's a really large calculi that's formed in the bladder. And the calculi, that word comes from calcium. These are made up almost primarily of calcium. They are typically called kidney stones, though, because the kidneys are the most common site for them to form, but they can form anywhere in the tract. The formation of them is called urolithiasis, so urinary tract development of these calcium crystals. And so calcium is an insoluble stone. It forms crystals, and crystals are really difficult to break down. These are some examples of real kidney stones that were passed. So these ones look like those gobstoppers from the Willy Wonka and the Chocolate Factory movie. And if you can imagine those moving through the ureters and the intense pain that will cause. Look at this one is almost 7 centimeters long. Like, just look at this. This looks miserable. So you can imagine when these are passing through the tract, they cause quite a bit of pain. So when they're tiny, so many are passed without symptoms because they're really small. And when they're really small, you might not even notice them. Some cause really intense pain. There is a referred pain with these, and it's actually really interesting to me when they're going through the ureter, because of the dermatome region, like where nerves go on your skin. The referred pain of a stone moving through a ureter is in the vulva in females and then the scrotum in males, because those are the same redundant tissues in males and females. When they get lodged somewhere, so if this one gets lodged in this neck of where the ureter hooks into the bladder, you get not only intense pain, but urinary stasis and then backflow. And remember, when urine flows back up, that causes a lot of damage to the kidneys. When they are large, like these ones, and they get impacted or stuck, that disorder is called renal colic. You've probably heard the word colic before, like with babies. Whenever you hear colic, that means it's really bad. It's causing a lot of pain. There's biliary colic when a gallstone gets stuck and it causes intense pain on the right side of the body where the liver is. And then there's renal colic, which causes intense pain that can go all the way from the ureter to the upper leg portion. People are very sick in renal colic, again, chills, fever, and hematuria. In this case, it's not because there's an alteration to the renal tubules or the glomerulus. It's because these are sharp calcium crystals, and now they are cutting either places in the ureter or the urethra. They're almost completely made of calcium. So this is typically associated with things like lots of calcium intake or vitamin D intake, because you need vitamin D to absorb calcium. So we recommend, for many reasons, that people not supplement calcium unless they're deficient in it. When these are small stones, so small stones are called simple stones. So when I say small, I'm talking about like in reference to one of these guys. So this is a really big one. We're not going to sonicate that. But when they're simple stones that might get lodged and create some pain, the process of removal is called sonication. And the sonic there is for sound. So this is when ultrasonic sound waves are used to break up the stones. That's just called sonication. If you've ever had jewelry cleaned before, that uses a sonicator. So it just puts it in a substance and it vibrates really quickly back and forth, and then the jewelry gets clean. So same process here. The sound waves break down the stones, and then the stones can be passed then through the urine because they're small and they should cause minimal amounts of pain, more likely that referred pain to the vulva or scrotum area rather than the really large stone renal colic that will cause the ureter to leg pain. If they are bigger than just a simple stone, then the next thing is percutaneous nephrolithotomy. An otomy means to cut into, not to cut apart, to cut into. So percutaneous means going through the skin and cutting into the kidneys. This is when there is a shunt that is inserted into the skin surface. On the other side is a scope like you would see in a bronchoscopy or a colonoscopy. So there's a camera, and then there's also something that can grab things. So this shunt is put in, and then the guide cannula goes into the kidneys, grabs the larger stones, and then pulls it back through this percutaneous shunt. When we look at really large ones like this, percutaneous is not going to be the best way for removal. That's going to have to be taken out through a more severe abdominal surgery. So usually you'll see sonication for smaller stones or percutaneous nephrolithotomy for larger ones. And the other way that you can tell where something is lodged is wherever there's something lodged, you will see that the area above it becomes really big, okay? So think about your kidneys, they're kind of like a balloon. Yeah, that's a good way to think about it. So here's a balloon, and if it was attached to a tube, if something gets stuck in this tube, this balloon's gonna get really big. Okay, so looking at CT scans or even a sonogram of an area and looking at the size of different areas of the kidney will tell you where the obstructions are. So you can see if they're at the neck right here, at the pelvis where it hitches into the ureter, if it's at this uterovesical junction, if a lot, like there's a really big blockage on both sides, you'll see both sides affected. And the words you'll see are hydro, so that means water in the kidneys or development of water in the kidneys, or hydroureters, development of water in the ureters. Okay, so let's take a look at this. Wherever there's a blockage, so blockage of urine outflow, progressive dilation of urinary tract proximal to obstruction. So that means above. So just like I said before, now I'll draw a kidney, and then here's the pelvis coming off of it, and then here is a ureter. This kind of looks like a femur neck right now. That's okay. Here, kidney. Okay, so if there is a stone stuck right here, you will start to see this balloon up, and it is going to fill with urine. So wherever the blockage is, everything above that is going to become dilated. So that can be seen as either hydroureter, dilation of the ureter, or hydronephrosis, dilation of the pelvis and calyces. Okay, so here's some rules. If it's bilateral enlargement, that means something is blocking the whole tract. I'll show you that on the next slide. If it's just one side, if it's unilateral, like in my picture here, only one side's going to be dilated. So if both are dilated, it's going to be either a prostate problem or the urethra has become scarred and isn't healing properly, and you're getting backup of urine. So this is complicated by stones and then the resulting infections, because now we have stagnated urine and then we have bacteria, and this can cause pyelonephritis. So you want to diagnose this by a pyelogram so you can visualize the inner structures, see if there's any diverticulum in there. So you might have seen that here, thickened bladder wall with diverticula. We talked about diverticula in the GI tract, where there is so much contraction that the connective tissue starts to bulge out. And when there's diverticula in the bladder, that makes emptying the bladder really difficult too. That's just a sign that the muscle is contracting too hard. Muscles contracting too hard. That forces some of the connective tissue out here, and that can hold urine in it, and that urine can pick up bacteria. Okay, so here in A, we have bilateral. Both sides are dilated. So we see dilated pelvises, we see dilated ureters. When both sides are affected, that tells us that it's something urethra related. It's either that there's a stricture, so a complicated healing in the urethra, or in males, it means that the prostate, which is right under here, is getting bigger. So both sides means urethra. When it's just one side, like in B, so here we have hydroureter, so the ureter is big and dilated, and we have hydronephrosis, meaning that the pelvis is filled with urine too. So this is indicative of just one side above the bladder being affected. And that should make sense, right? Because if it's above the bladder, so if there's a stone over here, why would this side be dilated? Well, it wouldn't. So that means that something is stuck above the bladder in the ureter. Then there's just unilateral hydronephrosis, so there's no dilation of the ureter, but there's dilation of the pelvis. So there's a little arrow that's showing you exactly where the blockage is. So that lets you know where it is, and then you can make a plan for how to remove it. This is what it looks like in real life. Isn't this crazy? So here is hydronephrosis and hydroureter. So here's tiny little kidneys. Kidneys are little babies. They're tiny. And this is all urine. So just imagine all the bacteria in here, all the pain. We can already see redness and inflammation, angry inflammation. And this is going to cause quite a bit of difficulty. Then if we take this and cut it open, look at how crazy this is. So not only did we have dilation that we can see on the outside, we also see that all of these calyces where the filtrate's flowing into, those are big and dilated too. So it's really important that we catch this before it gets to this level. Otherwise, there's going to be a change to the inside of the kidneys and then the outside. For those of you patho lovers out there, oh my goodness, yeah, let's do sparkle. Oh, that is fancy. What are these, guys? Do you remember what that is? These are little pinpoint red spots. Who can tell me what those are? Are they, this is so magical. Are they called petechiae? I can't even spell it that way. It's Petacia? Is it Petacia? It is. Petacia, remember, is a sign that platelets, this is too much fun, I've got to stop, so that platelets have run out in that area. And now we're seeing these Petacia pop up, telling us that there has been a bleed in that area. Now there's a low amount of platelets. This picture was a little bit magical. So that's hydronephrosis, dilation distal to a blockage. Okay, so we're getting to the end of our kidney diseases. Now we're going to talk about one that there is a genetic implication for. It's called polycystic kidney disease. And you can see why it's called polycystic. Poly means many and cysts means cysts. So polycystic kidneys. So these kidneys are covered in cysts on the inside and the outside. So just like we have scar tissue having no function, cysts have no function either. This is, I shouldn't use the magical one on here because this is awful. These are the largest ones ever removed from a patient. So just look at the nurse's hands in relation to the size of these polycystic kidneys. What you see if we're looking at a person, they think that they're gaining weight. It looks like abdominal obesity when they get this big, but it is the prevalence of polycystic kidney disease. This is something that is genetic in nature. There's two genes. There's PKD1 and PKD2. If you have one of these, there's going to be problems with the functionality and the appearance of the kidneys where they're polycystic in nature. If, though, there's both genes present, that's very, very bad. And that's going to lead to not only really large things like this in an adult, but typically, if we go back to the first picture in this lecture with renal abnormalities, we can see that this is an infant. So this is an infant. You actually can't see the rest of the body. That's the belly button where the umbilicus was. So this grows in utero in some individuals, and this is not compatible with life, unfortunately, if there are both genes that are present in that individual's genetic code. So you can screen patients for it. If the kidneys are not filtering blood appropriately, the blood backs up in the system, and that is going to raise the blood pressure. And when that BP goes up so high, that causes a raise of pressure everywhere. And the other thing that can go wrong and cause death is cerebral aneurysms. So it's important that people be screened for this. If they have a family history of polycystic kidney disease, it's recommended that they find somebody that's a donor match for them early if they're going to progress to a disorder like this. Okay. And then in the final failure state, like you saw in the last slide, this is a genetic disease. So this is PKD, polycystic kidney disease. That is different than renal failure, even though you are going to see cysts appearing on the kidneys when they start to fail. That looks different than these bloody black yellow cysts. We're just going to see this general cystic nature. They're almost like nodules, like granulomas. So when the kidneys start to fail, one of the first signs is going to be uremia, which is uric acid in the blood, and urea in the blood. Urea, as we know, is one of the products of urine. That's how nitrogenous wastes get eliminated. So we definitely do not want uric acid accumulating in the bloodstream. When the kidneys start to fail, they're not going to remove waste products. So those waste products remain. And also remember that a concentrated urine is going to be mainly water and then also contain waste products. So if the kidneys aren't doing that, there's going to be water retention. There's going to be changes to acid base because the kidneys are responsible for doing things like urinating out extra hydrogen ion or bicarbonate so that we can maintain the pH balance in the body. There's also supposed to be secretion of potassium in the nephron. So if we see alterations to potassium, if you retain too much of it, that is going to cause abnormalities in the cardiac system and skeletal muscle. You'll see the same thing with calcium, but it's the opposite effect. So signs and symptoms: nausea, vomiting, loss of appetite. Pruritus means itching, because when there's a lot of waste products building up, that is going to affect the other systems in the body as well, causing some itching. Loss of body weight due to anorexia. Remember, anorexia means a lack of orexin activity, so a lack of hunger. Once it starts to hit the central nervous system, people feel confused. They don't care about anything happy or sad. They're not angry. They're not mad. They're just apathetic. And then that progresses into convulsions and then possible coma. There's platelet factor inhibition, so that there's abnormalities, clotting. And this is one of the things that can cause pericarditis, where there's a buildup of uric acid in the bloodstream, and then the outside of the layers of the heart become thickened and roughened to try to protect the heart from that hostile environment. So in acute renal failure, this, just like jaundice, can either be pre-renal, meaning something before the kidneys. So maybe it was shock. So the kidneys experience an interruption in blood flow because of illness or stress or severe injury. So that could be a common or just a cause of really acute, kind of short-lasting or acute renal failure. It comes on all at once. They were starved from blood. It can be intrarenal, meaning the kidneys themselves were damaged. So that could be because of drugs, toxins, an infection, or reduced blood supply to the innermost areas of the kidneys, like we saw in malignant nephrosclerosis. Or it could be post-renal, which is when there's something after the kidneys, blocking a ureter, causing stagnated urine flow, or anything bladder, prostate, urethra related that would stagnate and then lead to the kidneys failing. The dominant feature there is oliguria or anuria. So oliguria is a low amount of urination. Anuria means no urination. That's dangerous. You'll see this again after circulatory shock, and ischemia or toxic injury are the most common cause and cause tubular necrosis, which is very bad. The tubules are the functional parts of the kidneys. This can be reversible if blood pressure is restored and the individual gets pushed fluids and they increase their urine output. This can be reversible. That's good news. Acute. That's different than chronic renal failure, where there's a steady functional decline in nephrons. Once people get to the level of chronic renal failure, they're either going to have a dialysis protocol put in place or a transplant. Fun fact is, when people go into the hospital and it is determined that they're in renal failure, at least in New York State, they have to remain in the hospital until they have a dialysis protocol set up for them. If they're traveling from out of state, that means that they're going to have to stay there while the physicians navigate with the general practitioner at that person's house or hometown to get them on a dialysis protocol. So chronic renal failure is from a lifetime of kidneys gradually losing their ability to function. So you'll see things like headaches, decreased ability to concentrate, excessive urination progressing to low levels of urination. Here we'll talk about the waste product. You'll see increased levels of blood urea nitrogen and then serum creatinine. We shouldn't see really any creatinine in the serum because anything we make, we should pee out. Edema because of fluid retention. The rate of glomerular filtration decreases, so then we have waste products build up and fluid build up. Mild anemia because, remember, the kidneys make EPO, which you need for red blood cells. You'll have increased blood pressure because when blood flow is reduced to the kidneys, you see an increase in the production of renin, because renin is only released, hopefully, when blood flow to the kidneys is decreased. And then people feel weak and fatigued. When you're looking at the progression of typical chronic renal failure, I want you to notice that the size of the kidneys is going to start to change. So this is called end-stage kidney. The kidneys are at the end of their life plan. They have excessive water loss and they appear polycystic. So here is starting off the size differences in chronic renal failure. So here's the initial kidney. It starts to become scarred and fibrotic and become smaller. And at the final stages of end-stage kidney, it looks polycystic in appearance. It is very, very small, and then it loses functionality. So the progression is going to be scarring and then cyst making of the kidney. So the first step while waiting for a transplant is dialysis. And there's two types of dialysis. There's hemodialysis. That is hemo's blood. So that's using something called a hemodialyzer. And the hemodialyzer is going to take the place of the patient's kidneys. There is going to be one tube inserted to take out blood. That blood will run through a tube into the hemodialyzer, and then it will go through a variety of different tubes to force out the waste products. Then the clean blood, hopefully it's clean by this time, is going to flow back in to the patient's other port. So we're going to have the blood taken out, clean through the machine the way that the kidneys would clean it, and then the clean blood back in. So this, depending on the level of somebody's kidney function, they might have to go 3 times a week, 2 times a week, 5 times a week. And this is a couple of hour affair. If there's limited mobility issues, things of that nature, it can be really difficult. So the other type of dialysis is peritoneal dialysis. And remember, the peritoneum is the lining of the abdominal cavity. This uses, instead of a hemodialyzer machine, the patient's own peritoneal membrane, which is a serous membrane, meaning it's easy to get the flow of things through it. This is when there is a port inserted into a person, and then they have a variety of fluids. They have one for after like high protein meals, high sugar meals. They pick out their diacylate fluid and they hook it up to the port, and then using gravity drainage, all of the fluid that accumulates in here from the diacylate fluid will, through osmotic principles, force waste products out through a catheter and then into the just waste fluid bag. So this is ambulatory, meaning that it can be done at home. You don't have to travel to a dialysis clinic. The risk, though, is really inflammation of the peritoneal cavity. We had a cadaver here a couple of years ago who had a peritoneal dialysis port, and once they opened up the abdomen, it was really difficult to even tell any of the structures inside of the abdomen apart from one another. So Todd Stevens just said, close it up, and we couldn't use the abdominal cavity. So it does cause quite a bit of damage over time. But it does provide the possibility of ambulatory means of getting dialysis without needing to take 2 to 3 hours, 2 to 3 times a week to have dialysis at a clinic. And then the final thing that is hopefully the end goal of somebody going through dialysis is the receipt of a grafted kidney. So fun fact, if somebody gets a grafted kidney, they don't take out the non-functional kidney. What they do is give them an extra kidney, and it's actually right by this iliac version, this area. This is your ischium, and it's attached to the iliac vessels. So they have an extra kidney. They have 3 kidneys. If it's coming from a live donor, it can live without dying of infarct for about 1 hour. If it's cold ischemic time, meaning it's on ice, the kidney can stay alive for 4 to 10 hours. So when the kidney's available, you got to come in. You've only got a couple hours to make it, and there's a transplant list that people are waiting on, and the United States has a huge shortage of organs. If you're interested in becoming an organ donor, you can see some of the information on the unit's website to learn more about becoming an organ donator. It's also important that there is immunosuppression used so that the person does not reject their donated kidney. So there will be the necessity for having immunosuppressive drugs on board while the kidney is there. Finally, these are the assessment tests to see the function of the kidney. There are blood tests, so you can look at creatinine levels. Again, creatinine shouldn't be present in the bloodstream. It should be peed out. And then you can look at the BUN levels, which is blood urea nitrogen. There's clearance tests, and clearance tests are when there is a collection of urine, usually for about 24 hours. I've seen people do it for 48 hours, where people just pee into one container, and that gives you a good measure of what is actually in there after a day or two. And you can then look for things like creatinine, urea, inulin, and then there's just simple urinalysis. Pee into a cup, send it off to the lab, check out the volume, the specific gravity, the protein levels, look for particulate matter, look for bacteria, and that's the end. So here is your final question. A male client comes to the emergency department complaining of sudden onset of sharp, severe pain in the lumbar region. Okay, so lumbar, think about that, which radiates around the side and toward the bladder. The client also reports nausea and vomiting, appears pale, diaphoretic, and anxious. The physician tentatively diagnoses renal calculi and orders flat plate abdominal x-rays. Renal calculi can form anywhere in the urinary tract. What is their most common formation site? This is a super typical board question in that right away, if you read this, you would start thinking about this, and that actually doesn't matter. The only thing that matters is this last one. Renal calculi can form anywhere. What's their most common site? They're called renal calculi, which means kidney. So that is leading you towards kidney. They can form anywhere. But that's a really important thing to do, is figure out like what the question's actually asking you. But I just want to also go through really quickly. Okay, sharp severe pain, lumbar region, radiates around the side. So we talked about radiating pain. That tells you it's some sort of kidney infection, or if it's sharp severe, that is that colic. So that means something's blocked, okay? The patient is sick, they're vomiting, they're pale, they're sweaty, they're anxious. So these are all signs that there is an infection and that there is a blockage. There's an impacted stone. However, the question then tells you that renal calculi. All right, does that make sense, everybody? Kidney lovers? Hopefully it does. And I will talk to everybody later. Enjoy your lives, kidney friends.